too, which they do on a routine basis. So I want to talk a little bit first about me and my family, so people sort of get to know like the person behind, you know, the professional. And I actually grew up in Santa Monica, California. So, you know, Santa Monica is back then was a very low-key community, and that's sort of the way I am, you know, very just, you know, down-to-earth, regular guy. And, but when I met my wife, I was a counselor at camp at summer camp, and so she was a counselor too. And so I sort of knew she was the one back then. We were 18 years old, but it took about a good 6 years for her to recognize that. So I stuck with it, and so Selena, eventually we got married, and we just had our 23rd wedding anniversary, and that was great. I made her a jigsaw puzzle of our wedding picture as the present, so that was really a fun surprise for her. And then eventually we had 2 children. We have twin girls, and they just turned 10 years old. And they've been a lot of fun. I try to really spend as much time as I can outside the office with them, because those of you with children know you have sort of a finite period of time with kids before then they sort of are on their own. And so one of the things I really like to do is with one of them here, let me see if I get the pointer working. Well, this one here, I'm the coach of our basketball team, so that's been a lot of fun too. And I can tell you, it can really try your patience when you're trying to corral a whole bunch of like 9 and 10-year-old girls, you know, but it's been a lot of fun with that too. So I think I'm going to skip over a lot of this. I think Jen just went through a lot of, you know, credentials and information there, but I have spent a lot of time trying to educate colleagues and the public about keratoconus treatments, including 3 books that we've published on keratoconus as well. So let's just dive right in here. So what is keratoconus? Well, keratoconus, the way I like to think of it, it's a hernia, like a hernia in your groin. And that's really what's happening because keratoconus involves a weakening of the cornea, the collagen in the cornea, and it bulges out just like that hernia does. And that's why when you think of like what is keratoconus, if you think of it like a hernia, that'll make a lot more sense to you to understand what's happening. And it can cause a lot of problems, a lot of vision problems, a lot of frustrations, and it can really derail somebody's ability to lead a normal life. And these are just some common things that you might be able to relate to. You know, if your doctor told you the only thing you need to wait for is just a cornea transplant eventually, and just that's going to be what is going to be in your future probably. Many people are afraid of cornea transplants, and rightfully so. Traditionally, in my training years and years ago, I was trained in cornea transplants. It's an invasive surgery. It's got some serious risks, including blindness, retina detachments, glaucoma, and one risk that is really very rarely ever shared by surgeons to patients who are being counseled for cornea transplants, it's almost kind of glossed over or just sort of ignored, is that for the rest of your life, if you get hit in the eye, your eye is very susceptible to being rupturing open the transplant, and basically the contents inside the eye coming out like a squished grape. And I've been called to the emergency room where I'm on staff at Cedars-Sinai many times in the middle of the night because a patient who had a cornea transplant got a little bump, and that's exactly what happened. And typically it's going to end up being a blind eye that may even have to be removed. That's one risk that is almost never shared by surgeons about cornea transplants to their patients. But these are some other things. People can feel very hopeless. They can have bad glare and halos at night, even giving up the ability to drive at night because of that. People can get very depressed over this. And if you haven't read Stephen Holcomb's book, he talks about that. He'll be speaking later today in the symposium. So you definitely, you know, if you're watching on live stream, you want to make sure you watch that talk. It's going to be amazing as he really opens the kimono on his experience. People can be concerned about passing the driver's test at the DMV. And then also, a number of people went in for LASIK and found out that they had keratoconus, didn't even know it too. It's not uncommon for doctors to not tell patients about these other procedures. If they don't have expertise, sometimes, as you heard from my TEDx talk, a lot of times a doctor's ego gets in the way and they may tell patients, which is in the best interest of them, that there's other procedures that are outside of their office. Happens all the time. We see patients who fly in all the time. A doctor never told me about these things. I found out about it on the internet. It's sad, but at least if you're here, you're being educated, so you're going to be up to date more than a lot of doctors out there. And people can feel, that there's no hope, and they're very concerned about it getting worse in the future because it is a progressive disease. So for the many, many patients who are told, just get hard contacts or wait till your vision gets bad enough for cornea transplant, I mean, that's like a dentist telling a patient with a cavity. Imagine your dentist telling you if you have a cavity, well, we're not going to do anything about it. We're just going to wait until it gets so bad that you have to then just get your teeth replaced. I mean, can you imagine your dentist saying that? Of course not. But when eye doctors tell patients that with keratoconus, that's essentially what they're saying. And that just makes absolutely no sense. Does anybody, raise your hand, does anybody feel that makes any sense? Of course not. So because of what we've been doing, really cornea transplants in my practice are a thing of the past because of these procedures that we're going to go into. But we first have to actually look at how do you look at a topography map, which is a map of the cornea. That's really important. So I'm going to go through almost like Topography 101 because I'm going to be showing a number of maps in the talks. So the first thing here that we look at, and that usually jumps out, is this red area. So this is a map of the cornea. Red is and yellow is where it's more steep. So it's like bulging out. That's the hernia, if you can imagine that. But the other side of the problem with keratoconus that also gets overlooked and ignored a lot of times, that the blue above is too flat. So if you look at these measurements here, on the scale, okay, going to the warmer colors is steeper, cooler colors is flatter. So for example, in this patient, the pupil is the black circle, and they're looking through steep and flat at the same time. That is what causes the distortion. Regular glasses and regular contacts cannot correct that, okay? That's why you get double vision, halos, multiple images, and loss of vision because of this. And then also, when we look at the K readings, this is actually the numeric value on how steep or flat the cornea is. That's another metric that we look at as well in astigmatism too. So those are some of the ways to sort of think about looking at a topography map. These are some, I'm going to show you now a whole bunch of different topographies, and we'll go through this kind of quickly. But the steepness and the flatness comes in all these different patterns. Everybody's different. It's almost like a fingerprint. It's unique to each person, which is why when we're planning treatments, we customize it for each person. You cannot take a cookie cutter approach, like one suit fits all. And you can see why here. So here's one pattern of keratoconus. And then here's another pattern, but I wrote KE up here for keratoectasia. So keratoconus can occur after LASIK or PRK, which are vision correction procedures. Many times it can be years afterwards, or it could be soon afterwards. But essentially in my book, it's still keratoconus, even though some doctors call it ectasia. But it's, at the end of the day, it's still keratoconus, and we treat it the same way. But there's another pattern, and here's a different pattern. You can see how the red and yellow is different there. Here it's off to the side, the steepness, and meaning the flatness is over on the other side at an angle too. Here's a more horizontal, but a little tilted with more pattern up there. And this was a patient who had LASIK PRK in the past. Again, here's another example. So it's very different. Again, just think of it's like a fingerprint in terms of how unique it is. Very early stage keratoconus will not have the steepness get too much into the center of the vision or center of the map. And that's why in early stages, the vision may still be good, but we can still see some steepening. And for parents who have children with keratoconus, I recommend around age 10 having your children, 9 or 10, start being tested, because if there's a little sign of this bulging before they've lost any vision, then they can get stabilized and strengthened before they've actually lost any vision. Now, there's another diagnosis called pellucid marginal degeneration. Some of you may have heard of that, or just known as pellucid. So it's actually still keratoconus. It's just a descriptor of where the bulging is occurring. It's a little more outside. It looks like a crab claw, and that's pellucid. but it's still keratoconus. It's underneath the keratoconus umbrella. It's just a description. So some doctors will make a distinction that they're two different processes, but they're actually, it's still keratoconus at the end of the day. So if you've heard of pellucid, just think, okay, it's still keratoconus. Now, there's some basic things, well, number one for everybody, and especially for people with keratoconus, that are important to recognize. Number one is wearing sunglasses, particularly the kinds that wrap around, not like the kinds like a Ray-Ban style that just comes straight across. It still lets a lot of light and UV sunlight in. It's the ultraviolet light that's dangerous. It's dangerous to skin collagen, causes skin cancer, aging. We're going to talk about a study that we just had published 2 days ago regarding this, regarding your cars and where you're getting exposed. But if you wear wraparound sunglasses, it really helps block a lot of the UV light from the sides. And then also not to rub the upper eyelids. On the sides or in the corner, rubbing and lower is okay. You're pushing on the bone, but don't rub above because that friction can cause increase in free radicals. And Dr. Kinney, who's here, is going to talk about the cause of keratoconus afterwards. But that's based on some of the discoveries that she actually made in her laboratory. And she's going to talk about some of that too. But yeah, don't rub your eyes, especially the upper eyelids. The other areas are okay. So this was a study that was just published in JAMA Ophthalmology just 2 days ago. And it really just got covered and picked up by all the press because it has such potential impact for anybody who drives a car, which is most people. So basically what we found was that we measured the UV protection through windshields and side windows. And by the way, there's lots of dermatology studies that show much more skin cancer on the left side of the face. In North America and in Australia, it's the opposite. They drive on the other side of the road and they have more skin cancer on the right side of the face. So we measured the UV level protection coming from windshields and side windows, and all the windshields had good protection. It's actually mandated by law. But the side windows, protection was all over the place, and it was much lower on average than the windshield. So that was that study, and basically the take-home message is to look into your car windows, and if you don't know for sure, we actually have, and we have here for everyone who's here, a little card that you can get where you can measure the UV, and if it turns purple or degrees of purple, it means you're getting a lot of UV coming through your windows. Versus staying relatively white or just very light pink. There's a strip that will measure. You can put behind your window, side window, and the windshield. And if you're just not sure, just have somebody do aftermarket window coating who does, they do window tints usually, but make sure it's a clear film, non-tinted, and it will block most of the UV on the side windows and protect you. Also, there's more cataracts on the left side as well. So how do we treat keratoconus in post-LASIK or PRK ectasia? Well, these are the procedures we're going to cover. Holum C3R, which is non-invasive cornea cross-linking, Intax, conductive keratoplasty, CK, and the Visian ICL lens implant. So Holum C3R. So first of all, it's a 30-minute, completely non-invasive treatment, and we've been doing this. It was invented back in 2003. And as Jen mentioned, I invented the procedure, and it actually has the longest track record of any type of cross-linking, even the one called CXL where they scrape off the epithelium. So it's got the longest track record in the world of any type of cross-linking except in Germany, because there's a group in Germany who developed the invasive CXL procedure. And of course, for epi-on cross-linking, it's the longest follow-up in the world, and I'll give you some examples there. And this just shows, this is the key for any type of cross-linking to work, is you need to get the solution that has riboflavin into the cornea. So here's some examples of completely intact, undisturbed epithelium, but the yellow shows the riboflavin solution in the cornea completely. And there's in a patient who had Intax, and in the sequence, we'll do this right after we do the Intax procedure on the same day. But that shows you the riboflavin in the cornea, and here's a patient just had Holum C3R. It shows you the riboflavin in the cornea. So how do we get it into the cornea? Well, we have a proprietary solution that we developed. It took a long time to make this work, and it actually opens up the channels in the skin of the cornea called the epithelium, so it allows the solution to get into the cornea, and that's without scraping or puncturing or doing anything invasive to the epithelium. Now I want to show you what it looks like when the epithelium gets scraped off. There's some kind of instrument typically that's used, and it's just kind of scraped over the cornea. This might make you a little uncomfortable, but my job is to just show you the truth and reality about things. And then this is a video of it actually getting scraped there by a surgeon. So that's the invasive part of the CXL procedure. And that's why we'll go through in my second talk about the risks and side effects of having that done. So the mechanism here for Holum C3R, or actually for that matter any type of cross-linking, is that the ultraviolet light reacts with the riboflavin that causes the cross-linking or strengthening, because the cornea is made up of collagen, and then that gives a stiffness and stability. And it also makes the collagen not just more cross-linked, but also the collagen fibers thicker, in fact. And that's been shown as well. There's more cross-linking between those fibers in the cornea. So this is one myth that is sometimes out there, is that C3R is it allowed to be performed? Well, it's considered an off-label procedure, which is done all the time in medicine. That's how most advances are made, by being off-label. Even aspirin originally, that was used to prevent heart attack and stroke, it was approved as a pain medicine, and then doctors were using it off-label, saying, this is good for stroke prevention and heart attack. So this is no different than anything like that, and doctors are certainly allowed to do that. Holum C3R is not experimental. It's been 13 years to the test of time, having a 13-year track record at this point, and it's not in a clinical study or clinical trial. And it's just been a normal part of our practice, our daily practice, since 2003. Now the safety profile is really high. I just talked to you about UV light. Well, we do use some UV light with this, but it's 500 times weaker than the sunlight if you were in the shade. And we measured that with our meter many years ago. So if you've been outside with no sunglasses in the shade for a half an hour, during that half an hour you had 500 times more UV exposure than you get with Holum C3R. So it's very dilute. There's been no side effects at all from this UV. Never had any complications, and that's also with some other doctors too who were doing the procedure around the world. It's a one-day recovery, and that's also very typical. Typically no pain, never had an infection, never any scarring or hazing, no cornea denervation or nerve damage, which can happen when you scrape off the epithelium with the CXL. Never any cataracts, never any endothelium, which is cells on the back of the cornea issues. So just really, that's what you would expect from a non-invasive procedure. So our indications for using Holum C3R are keratoconus, ectasia after LASIK and PRK, which again is keratoconus too. Patients who had RK or radial keratotomy, they have unstable corneas because of those spoke-like incisions. So we can help with those patients. We can't give 100% stability, but we can slow down the RK patient progression and fluctuations. And we also routinely combine Holum C3R with Intax as well as CK and Visian ICL. And even after PRK, there are some patients where we'll do PRK and then do Holum C3R afterwards to strengthen their corneas too. So I'm not going to go over too much of this because Jen talked about it, and Stephen Holcomb's going to be here later and talk about the experience with the Olympics. But after Stephen won the gold medal, that really, like I said, pierced the vocal cords of many of the critics because essentially there was a gold medal behind the procedure. And so when we look at our data, the long-term data, we have an average of 1.3 diopters of cornea flattening. But in my talk in the afternoon about comparing Holum C3R to CXL, I'm going to say that that is a misleading statistic. And I'll just leave you with that, and we're going to go through that in the second talk. The real statistic that you need to look at is what's the progression rate of any cross-linking procedure. That tells you really how effective it is. And again, second talk is going to go through that one in the afternoon. So you definitely don't want to miss that, come back for that one. But we have a 0.7% progression rate, less than 1% of people who progress and need a second treatment. which means we have a 99.3% stability rate, and that's just with one treatment. We presented this study many years ago as well at 2 different big scientific conferences. So here's a case example of Holum C3R, pre and post, and then these difference maps. And I like to always look at difference maps because a lot of times this can show what changed. So here's just an example of getting some flattening from the procedure itself. And this wasn't with Intax. It's not the goal or intent to give cornea flattening, but sometimes we do. And I just think of that as like a little bonus or a cherry on top. Intax, as we'll talk about, really that's the goal, to give cornea flattening. But sometimes we do with this procedure. Here's another example of getting some flattening. Now here's a patient who was 13 years old when I first treated him, and this was back in 2004. And you can see his different maps going from 2004 here to 2005 to 2011 to 2015, and certainly there is no worsening of his keratoconus. That's the right eye. So this case right here that I'm showing you is certainly one of the longest follow-ups that you'll ever see for any type of cross-linking. And this is, of course, Epi-on Holum C3R. And this is longer than any other physician or center in the United States. Since, as we mentioned, we started this in 2003. Here's the other eye, same thing, 2004, 2005, 2011, 2015. You just look at the measurements, and you also look at the numbers. We're not seeing any steepening now. And so that's just an example of, like, as long-term as you're probably going to find for cross-linking with, and this is Holum C3R here. So very happy, and he was an athlete. He was playing hockey, he was a goalie, and he needed good vision, and his parents were elated that he was able to be helped as well. So this is the opposite of someone who took a wait-and-see approach with keratoconus. This was a 19-year-old student. She was diagnosed in 2003. At the time, she was doing well in soft contact lenses, and we diagnosed her with keratoconus, as you can see. And this is the astigmatism she had, which also is common with keratoconus. The right eye had less than a diopter. It's in pink, 0.75. The left eye had about 2.25, 2.25 diopters, a little higher in the left eye. And that's what her keratoconus looked like. We talked about Holum C3R. Unfortunately, she went to another doctor who told her, no, just wait until you need to get a cornea transplant. And so she waited, and then she came back almost in tears a year and a half later, and her keratoconus was just explosive. You can see how much change there was in 1.5 years here, from here to here, and that's all the steepening that occurred. Really dramatic, and her astigmatism went up to 4 diopters in the right eye, and her left eye really exploded. You can see the difference map, and then it's showing how much steepening occurred in that year and a half. 2 diopters of astigmatism up to almost 9. So now we had to add more procedures, Intax and CK, to get her back on track, when it could have easily been prevented had we just done the Holum C3R originally. So the point is, you do not want to take a wait-and-see approach with keratoconus. It doesn't make any sense. There's just no logical rationale to do that, especially when we have something that's totally non-invasive with a 1-day recovery. So parents, of course, also, children that are newly diagnosed, you do not want to wait, because keratoconus is even more aggressive with children. So, and that's why when we do the customization of our cross-linking amounts, children need the highest amount because we know they're more aggressive. Also, people who had LASIK or PRK that developed keratoconus, they also need more cross-linking than the average person because of the previous flap and laser treatment. They need more strengthening. But we do customize it actually for every person, the amount of cross-linking that we do. So let's talk about Intax next, because this is used very often with Holum C3R when we have to try to improve the vision. So Intax is considered, think of Intax as like a vision correction or vision aiding improving procedure. So they're tiny little segments. You can see that's on my finger there. And this is showing it actually in the cornea. And we usually use one segment like shown, but as you saw where those maps were, how the steepening was sort of variable from person to person, we customize where we put the Intax and also the thickness of the Intax. So it has to be placed just in the right way to get the effect that we want. And the nice thing about Intax, it's typically a 7-minute procedure. They're underneath the surface of the cornea, so even if people don't like wearing contact lenses or they feel their contacts and they're uncomfortable, you really typically never feel the Intax because it's underneath the surface. Sort of like putting a pencil, in a book. The top of the book cover is still there, but the pencil is in between, way deep down. Intax is very similar. And by the way, I've done Intax on my brother-in-law and sister-in-law. Probably, I think 13 years ago now, and they still talk to me at family functions, so everything's good with them. So certainly if it's good enough for my family, it's good enough for everyone else, and that's always the way I am with any procedures that we do. Yeah, so usually 7-minute procedure. Also, you can use the same analogy. You don't feel the Intax, kind of like a dental filling. Who here has had a cavity taken care of? Yeah, pretty much. Sometimes people are like, no, I never had a cavity, like adults. Wow. You must have bulletproof teeth. These are the people who can pull the train, with the rope. The teeth are so strong, I think. So in any case, if you've had a filling for a cavity, you don't feel it. Even if you have technically a little implant in your tooth, the Intax is pretty much like that too. And the material doesn't break down or degrade. It's made of the same material that the original cataract lens implants have been made out of, which has stood the test of time for I don't know how many decades, 40, 50 years. So the material is very inert, it will not react and doesn't break down. And the key is that it causes flattening. That's really why we use Intax, because we put them where we need to get the flattening over the steep spot. So in the early days, we were using 2 segments. So an upper and a lower segment, and it caused flattening over the whole cornea. And we definitely had some patients who improved with that technique. We had some patients who didn't do as well and actually may have gotten a little bit worse from the double segment technique. So and that we first started back in 1999, and we did publish a paper back then, My How Time Flies, that was back in 2003, which was the biggest study of the time for Intax for keratoconus. And then we started to think about, well, if we look really at the cornea, like I just showed you, half of it is steep, and what's this half up here? Flat. So then I started to realize, there was one patient I started to think about, well, if we're flat up here, why do we need an Intact up above? We don't. So then we started working with just putting one segment in, because it just targets this area. And we definitely don't want to make the blue flatter. If anything, we want to lift it up. So then we made this discovery that one segment is actually better than 2. Usually it's the more the merrier, not with Intax in keratoconus. So as it turns out, when you use one segment, you push down, but the upper part can push up a little bit where it's flat. So we get a little bit of what I call the beanbag effect. And most of the time, 97% of patients, plus or minus, we're using one segment because that's their pattern of keratoconus. And 2 segments is only maybe about 3% of people when they have more central keratoconus. So here's an example of the beanbag effect. So there's the before and the after, and it shows flattening. The red isn't as big. But again, when you look at the difference map, you can really see what changed. It's almost like the injection mold, what happened when you subtract before and after. This blue shows the flattening from the Intax. But look up here. It caused the upper part to pop up a little bit. So it got a little bit steeper in the flat area, which is exactly what we want. So that's why we use the one segment. It's that beanbag effect there. And that, in this case, is where the Intacs were placed. And here's another example showing where the Intacs were placed in pink. As you saw, they're clear, but just showing it pink here and showing the flattening and some of the little elevation up above. So you do get a little bit of that beanbag effect there, and it's very, very consistent. Well, I wanted to do a study and compare single versus double segments, and we did a matched group, and we published that, and we found that, again, you get better improvements in single segments. So we then developed a technique for doing this to really maximize the results. We've been using that now for over 10 years. But there certainly can be problems with Intax. We get a number of patients who come in from different parts of the country who've had Intax who say, you know what, it didn't work out for me. I'm actually worse. And so we look at this, and it turns out that these are people, typically they had 2 segments placed. And not only were there 2 segments placed, but some of the surgeons put a thicker segment in the flatter area and the thinner down here. And the thickness of the segment corresponds to how much flattening you get. So the thicker segment, the more flattening. So to you all, does it make any sense to put a thicker segment in a flat area? We just talked about it doesn't even make sense in this case to put a segment there at all, let alone the more flattening segment. So these are why people can have problems after Intax. Basically, Intax surgery, it's a surgery, and it's just like a mechanic who has to rebuild a car engine. If it's not done just the right way, or you put the carburetor where some other parts are supposed to be, it's not going to work well. This is sort of similar. It's got to be done properly to get the results. So we actually published about that too, reduced vision from inserting 2 segments, especially in that order as well. So yeah, this is almost like the old video, videos like, Intax Gone Wild, a play on that one. And a lot of times for those patients, the story is, well, my insurance covered it, so I just went to my local surgeon. But they ended up regretting it. So in the end, a lot of people feel that certainly wasn't worth it. But we can fix it though. The good news is we can take out the segment, and if the lower segment wasn't placed right, we can remove it, exchange it for a different segment. So I mean, the nice thing about Intax is they're removable, they're exchangeable, so we can repair what didn't happen the way it was supposed to happen, and that's at least the good news. Now we do find we get the best results when we combine Holum C3R with the Intax. And so we do that on the same day. And it's still about a 1-day recovery for patients typically when we do that as well. And here's an example of where the Intax placed. And we also then did Holum C3R, and we get a nice flattening here. And in this patient, it almost looks a little bit like a symmetrical cornea now. So the results are always going to depend on where someone starts at their stage of keratoconus. So it's really important, my job, not only doing what I do technically, is also when I'm sitting down with somebody face to face and reviewing their test results, I have to explain based on their keratoconus what are your expectations. These are your expectations from the procedures, because where somebody starts with it being mild keratoconus or moderate stage or advanced, that definitely affects what the expectations are afterwards. And setting realistic expectations for me is really, really important, because we want to have people expect what to receive afterwards and not be unrealistic. Here's another example of before and after. And again, here's an example of somebody whose keratoconus was, they were still correctable to 20/25, even though they had a lot of distortions with the steepening, problems at nighttime, doubling and shadowing, despite what the chart showed. So a lot of times the chart doesn't even reflect what's in real life. Because you would think, wow, with lenses they're 20/25, that's pretty good. But if that's a 20/25, you might be able to relate to this if the letters are smeared, doubling, shadowing. It's not a really good quality 20/25. And it's because of that steepening and that flattening. So here with Intax and Holum C3R, we get a lot of improvement, a lot of flattening. Now this patient just happened to be ending up with uncorrected 20/20. So it's not all like that. Again, I have to set those expectations based on where everyone is individually. For other patients, it would be, our goal, for example, is to get you better vision out of your contacts that you're still wearing, and you'll still benefit from contacts afterwards. You may still have some more nearsightedness left over, you may have some astigmatism left over, and that's going to be correctable with glasses or contact lenses, just like if someone never had keratoconus and was nearsighted or had some astigmatism and no keratoconus, they still have to wear corrective lenses, right? So that's another factor that we have to explain to patients too. Or it might be someone can't even wear contacts anymore, And we do these procedures to try to get them back into contact lenses of some kind. So again, that's part of the goal setting. And it's individualized. Another example there. So yeah, it's really important that we look at each person's degree of keratoconus, and even people's eyes are different. You know, keratoconus is different per each eye. Typically it hits one eye first, progresses, and then goes to the other eye and progresses. That's why one eye is more advanced than the other often. So even the expectations between each eye is actually different for that reason. So in our study that we did, we compared Intax alone and Intax plus Holum C3R, and we found we got a synergy effect when we do them both on the same day. And that's why it's a pretty standard for us to do them on the same day, and this shows the K is that number I showed you on the topography. So we get more flattening when we combine the two, which is in red, the combination, over 2 diopters of flattening versus just Intax by itself, which is a little less than 1 diopter. And then this is really the key one. This is the metric of that steep and flat. It's called LU ratio that we developed. And if we do Intax by itself, we definitely, single segment, get some improvement in the LU ratios, meaning we make the keratoconus less. But the same day treatments, we get almost twice as much improvement in the keratoconus. That's the reason it's really important that we do it both on the same day to maximize the effect and improvement on the keratoconus. And we actually published this study as well. That was back in 2007. Now, another procedure that we'll combine when people have higher astigmatism and also more keratoconus, more advanced stage keratoconus, is CK. And it's not for Calvin Klein, but stands for conductive keratoplasty. And basically what we're doing is we're using a probe that applies little heat spots to the cornea. So I showed you, remember the blue area, the flat area? CK actually helps lift it up. So that's a lifting procedure or steepening procedure, and we put it where the cornea is actually too flat. And so it's not uncommon to combine Intax, CK, and Holum all in the same day. In the order, it's typically Intax and CK in the procedure room. Like I said, Intax is usually about a 7-minute procedure. CK is about the same, and then the Holum is a half an hour we'll do at the end. That sort of helps lock in everything with the cross-linking. So here's an example of somebody with astigmatism. Intax was below, CK was above, and you can see here we get the flattening, and also, well, actually we're getting a little bit of the CK, mostly the CK effect here of the astigmatism right there. So this is usually like at a 1-day type treatment. So there's always a little swelling when we combine it. And it can take a little time for it to settle down as well afterwards, for the swelling to go down and for the topography to normalize. And here's sort of another example. This is showing that flattening from the Intax after a little bit of healing has gone and the swelling has gone down. And then you see this is where we corrected the astigmatism or reduced it. It's going 90 degrees to where the astigmatism was beforehand. So in the difference map, it shows the astigmatism that we treated from the CK. Post-op is less up there too. Lastly, the procedure for people who have higher degrees of nearsightedness. For some patients with keratoconus, this certainly can be an option because the ICL, it's a lens implant. It goes inside behind the iris, and what ends up happening there is it's not really treating the keratoconus at all. It's just treating the nearsightedness. So it's also a procedure we use routinely when people are just nearsighted with no keratoconus and they're not good LASIK candidates because they may be too high nearsightedness. They may have a little bit of early steepening on the cornea. And even after people have had Intax and Holum, we can look at some cases doing this, for example. There were 2 patients this week we did Visian ICLs on for their nearsightedness after we had treated their keratoconus. And that just shows you where it is behind the iris. And this is the natural lens behind the iris, and this just shows the ICL there. And we have a nice gap or vault, as we call it, where the ICL does not touch the natural lens. That's the goal. We don't want it touching. And we have a special ultrasound that actually measures the internal anatomy as well to make sure we size the lens properly too. A lot of patients may describe their vision afterwards being more like HD. Again, it depends on where they're starting from before we do the ICL. So again, I have to set those expectations based on their individual situation. But if we're doing ICL and Holum C3R together on the same day, then it's usually about a 10-minute procedure for the ICL and then about a half an hour for the Holum, and then again about a one-day recovery. So if you're wanting to see some funny things about the ICL, a number of years ago I did a live surgery on the Today Show with an ICL procedure. Patient didn't have keratoconus, it was just nearsightedness case. But there were some funny things that happened behind the scenes. You can imagine with live surgery, there's always, you can't control everything. There's a lot of unpredictable things that happen. So there was one time when they were supposed to be at a commercial break and I got an itchy nose, and I asked Marie, my office manager, to rub my nose, but they had actually gone live already. And so there's literally me getting my nose rubbed by Marie, like live in front of the whole country. So we made a documentary about all these things that happened. So it's on our website called Behind the Lens. And it's an entertaining, short little film that we made about all these behind the scenes things that happened on this Today Show live surgery shoot. But it does give you a sense also about the ICL when you watch the patient go through the procedure too. So just a reminder to request from the office our free UV card to measure your windows. I'm obviously concerned about this enough that Jen's showing one right now. Can you hand one for me? Can I just, oh you have one? Okay. So for all of you watching out there live stream, this is what the card looks like here. It's just a little card and there's a little white strip here. And it's really easy to use. You just put this behind your windshield first. You'll see it won't change too much color. And then put it behind your side window with all the doors closed and obviously all the windows up. And if it starts to turn purple or light purple, then you don't have good UV protection and you should do something about it. And if you just put it outside, you'll see it turn dark purple instantly because obviously all the unfiltered UV just putting it outside. So yeah, contact our office. There's the information. We'll get you the card. Obviously we have our specialties that we do, but also as a doctor, I'm here to help people, and this is one thing why we did the study, because we feel there's a public health safety concern about this with all the skin cancer that's occurring, and people are under a false sense of security driving in their cars that they're protected. And another significant finding I'll just add before I wrap up is that I even thought if there were tinted windows, you're protected. Well, I was shocked because a lot of cars come with some factory tint, and those cars had it was no guarantee they were having full side window protection of the ultraviolet light just because they had a tint. So as I researched it, it turns out tint is only for the visible light you see. UV, it's ultraviolet invisible light. You can't see it, so that's why the film technically that blocks it, it's a clear film. It's a clear film. So some tints have the full protection, but you can't guarantee, take that assumption that you are protected with the tint. So thanks so much for all of your